All right, good afternoon, everyone. Good afternoon. It is great to see everyone here at Cambia Grove in Seattle. Today we have an exciting 2-for-1 event where we are having a conversation with Kurt Schieline with Echo Health Ventures and Dr. Matthew Thompson with UW Medicine's Primary Care Innovation Labs about preparing to pilot in the healthcare system. That's part one. Part two is we are kicking off our trails competition today. We are very excited to undergo the trails competition. This will be our third competition, and this one will be focused on physician burnout and how we better use data to make sure that patients and physicians are being taken care of in our healthcare system. So, I see a lot of new faces. I see a lot of folks that I know as well. For those of you who I don't know, my name is Maura Little. I am the executive director here at Cambia Grove. Cambia Grove, we are a healthcare innovation center, and we focus on advancing healthcare innovation throughout the country now. We host events, we have a number of programs and competitions, and we also, for those of you who don't know, we host this incredible co-working space, 9 to 5, Monday through Friday, and we hope the community will be able to take advantage of this space as you go and build out your healthcare solution. So with that, I am going to turn it over to Kurt and Matthew to come on over and get us started with part one, our conversation about preparing to pilot. Great to see you all. Thank you.
Thank you. Thanks, Maura. Hello, everybody. Kurt Schieline from Echo Health Ventures. We are an investment firm backed by Cambia and then Blue Cross North Carolina on the East Coast, backing startups and entrepreneurs in the healthcare IT and tech-enabled services space. Excited to have Matthew with us from PCI Lab. Matt, I've got some questions prepared, but maybe just kick off with background on yourself and a background on PCI Lab and what you guys are focused on.
Sure. Thanks everybody for coming, and I hope this is going to be informal and you'll be pleased to know there's no slide, there's no PowerPoint, and we're not going to be talking down at you. And I'd really appreciate back and forth questions, comments. So my name's Matthew Thompson. I'm a professor at the UW School of Medicine. My clinical specialty is family medicine, and I trained in the United Kingdom and again here in the States. I only see patients about a day a week now. And at the UW, one of my research interests is trying to bridge the gap between technology companies and the primary care research and clinical space. My theory, and I think it's proven, is that there's a big gap between us, and particularly in the primary care space where we've been maybe somewhat ignored with all of the advances in technologies that we see when we go to the hospital or the emergency department. Primary care has been a bit of the backwater of the healthcare system. So I'm really keen to try and bridge the gap between technology companies and the primary care research and clinical space, and particularly trying to find technologies that are going to make a difference, that are going to improve the efficiency of care, the safety of care, the patient-centeredness of care, lots of different outcomes that we could measure, and trying to generate that evidence for companies to go from, let's call it bench to bedside, or bench to clinic in our kind of perspective. So, yeah, thanks, and I'm looking forward to some discussion.
Well, primary care is no longer the backwater, as you probably know. So PCI Lab in particular, can you talk a little bit about how you guys like to partner with innovators and entrepreneurs, and for the people in this audience who I think are mostly that, kind of how would they start working with an organization like PCI Lab?
Yes, so we meet entrepreneurs, industry on a regular basis every week or so, and initially for kind of get to know you meetings and just seeing if there's a fit. Many times that there is a fit and we can see that there could be next steps. Other times we just may not be the right people in the School of Medicine or the UW or the Seattle area to take it further. So I think those initial, let's call them coffee conversations are quite helpful. Then if that's looking good, ideally for us, it's having a one-pager of what do people want to achieve out of this. And at that point, sometimes we get into signing NDAs or mutual non-disclosure agreements, just sometimes that's required. And then really trying to get very specific very quickly. And I think the companies or the industries or the startups we've worked best, we get very quickly to the point of what do we want to do, what do we not want to do, rather than endless meetings that go round and round in circles, because none of us have got time for that. And I think it does vary from the smallest startup to the largest companies. So we do some work with some large multinational companies, and they have a somewhat different approach. The bigger the company, the more lawyers involved, as you know. And the UW has its own, and I'm sure we'll get to this, we have our own challenges in terms of bureaucracies. We're a big, big, big state institution, and that comes with some greatness, but also comes with a lot of bureaucracy and lawyers and slowness to move. So I'd say that initial coffee conversation, getting quickly to a one-pager about what we each want to get out of it, and seeing if it's a fit, and if not, we can all move on and find other partners.
Can you talk a little bit about what organization, or what does and we'll get to the pilot word in a minute, but what does working with PCI Lab look like, right? Once you get past that first coffee conversation and you're starting to think about testing something in the field.
Yeah, so it can involve different things. So we've done everything on the range of doing health economic analyses of what's the market for a certain product. And that can be using big national claims databases to see, hey, I've got a product that does this. What's the likely market for this? What's the reimbursement for this? That's at one extreme. At the other extreme, it could be interviews, focus groups with doctors or patients to ask, would you use this technology? If not, why not? What are the barriers that you perceive that this would face when it's trying to be incorporated into your clinic? And with patients, asking patients, would you use this? If not, why not? That kind of qualitative research. And things in the middle could be exploring the diagnostic accuracy of a new test, comparing one product with another in different kinds of clinical trials. So some of these could be tens of thousands, some of these could be literally millions of dollars of research. So it's the range from cheap to expensive and from qualitative to quantitative in terms of research designs.
That's helpful, thanks. So I think we're here today to talk about pilots, the dreaded word in healthcare, I would say.
But not on an airplane. That's always a good word.
Yes, that's a good word in airplanes. Bad word in healthcare.
Yes.
I guess would be interested to hear your perspective. Why do pilots get such a bad rap, the healthcare version?
Well, yeah, the healthcare version. So I think it's yes. Yeah, so what I think of as a pilot, and I think it's a bit of a fuzzy definition, is a small initial piece of work or study or piece of research that we might do. I'd say it's as simple as that. And so let me give you some examples. For example, so a pilot study could be generally inexpensive and ideally could be done quite quickly, but maybe we'll come back to what quite quickly means, to gather data from a small number of clinicians, patients, sites about the initial value or perception or accuracy or usefulness of a product. That's my definition. There may be a more formal definition. And I think the problem is that this issue of pilotitis, you can keep doing pilot study after pilot study after pilot study, and many of us do, both academic researchers and industry, but they never really get to much definitive. They don't get to well, that's nice, you've done a study of 10 people, but we need data on 1,000 people. When's that happening? So that's a good question. So pilot studies could inform parts of regulatory submissions, but of course, regulatory submissions often have many other requirements in terms of sample size and numbers and who and how it's conducted and the rigor. So I'd say pilot studies are often slightly different or could be nested within a regulatory study, but often maybe trying to explore softer outcomes like acceptability or feasibility, things that the FDA will be maybe less interested in, but you as a product person will be super interested in. So for example, a company was interested in whether a new point-of-care blood test to guide antibiotic prescribing in primary care would be used in primary care. They did not want to go through the millions of dollars of FDA submission or clear waiver for that without figuring out, is there going to be a market for this? Or are we just going to... So we did some focus groups, interviews with clinicians, and they said, yes, we'd love this. When can we get it? But we would want to see some accuracy data before we started using it. So that could have helped that company to say it's worth investing the millions based on a quite inexpensive study. A very inexpensive study could guide, not solely, but could guide their investment in the millions in terms of doing a proper big regulatory study. I probably lost the track of the question there.
No, I mean, and I would also say it depends on the product and service, if there is even a regulatory piece of the pilot. Yeah. What we see a lot is, particularly in the tech space, pilots are used as a way to create a proof of concept around a product, right? And say, hey, we believe, it's basically taking a belief and then putting it into practice and saying, can we confirm or deny our belief? And then using that information to hopefully kickstart other prospects, right? And building a business.
Yeah, and I think the trouble is it's that initial, like you say, it's the initial, getting some initial data that can be helpful for investment decisions, showing that something seems to work. But I think the difficulty is it's never definitive. It's unlikely to be definitive enough for either FDA or perhaps for clinicians or healthcare systems to say, great, we can now adopt based on this small pilot study. And I think that's the challenge for innovators is how big, what kind of frequency and types of pilot studies do you need to actually get some traction? And hence the phrase pilotitis, doing pilot study after pilot study, but never quite cracking the nut of we need to do this big definitive study and who's going to fund that? Yes.
Would you also say that at times it's also might be a great idea, it might work and all of that, but there is no reimbursement for it?
What exactly? So the question was. So just to repeat the question, basically a question is to what extent does reimbursement get into this and how early can that be part of the equation? And I absolutely agree. And sometimes we've been able to do health economic studies to say, if you could do this part of, I think in one case it was a new alcohol screening tool that could be used in the waiting room, the market for this, the reimbursement for this would be substantial and they would pay for it. On the other hand, sometimes we come across companies where their product is going to cost more than the reimbursement, and reimbursement is often going down for certain procedures or CPT codes, and that becomes very challenging unless there's some other way of developing the value proposition, and we'll maybe get back to this. So reimbursement is part of the value, but particularly in healthcare, the value proposition is much more than just the reimbursement. I guess the other concept that comes to mind is often there's a mismatch of a pilot study might be really, really important, even crucial for a startup, whereas for either the healthcare system or academic researchers, often very unimportant. as an example, so the UW gets, what, $1 billion of NIH funding a year. So you can imagine a pilot study costing 10 or 20,000 doesn't make a big difference to the finances of a school of medicine or a university or the investigators. So there's often that mismatch between what we as academics in School of Medicine are driven to try and achieve, indirect supporting the university with what we could expect from a small startup in terms of funding. You can't afford a 54% indirect rate, which is otherwise known as overhead. Or if we were to do this in South Lake Union campus, I think it's a 75% overhead rate. Now, you just think of any dollar amount and you almost double it. That's really, really hard for startup companies to even conceive of. But that's our metric of success in a way. How many indirect dollars do we bring into the UW? So there's often this mismatch of goals and expectations, which I think it comes down to the challenges that you may be facing in terms of getting your foot in the door of researchers, clinics, healthcare systems, because they want to solve a problem, but they're just faced with these much bigger things driving their success and how they'll be seen as successful. And that's academic research, not thinking about busy hospitals who are trying to have other metrics of patient access and turnover time and getting people out of hospital, access to the emergency department and specialty. So there's all these other metrics, which I think is where pilot studies, the rubber hits the road, because we've got different expectations about what we need to do.
I think you're shifting there, so I'll take us there. So we talked about how pilots can go wrong. Yeah. So in your mind, how can they go right? Like, what are the top things for innovators to think about when they're trying to design a pilot for success?
This is probably could be a long list. I think one is engaging early with whoever it is, whether it's us or someone else, to figure out exactly what you want to achieve and how. People like me have great expertise in study design, how many people, what kind of studies, what kind of clinics. That's what I do. I live and breathe. That's what I do. And you all have vast expertise in many, many other things. And it's trying to bridge that gap in a very concrete, defined way. So exactly what is the aim of this and how will it be achieved? And those two can take multiple discussions to get correct. And done incorrect, it's like the garbage in, garbage out. If you start off with poorly specified goals, objectives, it all goes wrong after. Well, it can all go wrong after that. So I think very clearly defined goals and objectives. I think secondly is thinking about funding and an understanding of what it takes to get things funded. And some of this is challenging. I mean, in the University of Washington, we're a state university. We're not a private university. We're not making profit, but we are pushed to bring in bigger and bigger grants with bigger and bigger indirects. So trying to understand what it costs to do anything properly, just as if you were designing some tool or hardware or software. You wouldn't skimp on that because the product's going to be rubbish at the end of the day. You'd want the best you can afford, hardware, software, or product design. And I think it's easy to ignore those in terms of collecting clinical data. Sometimes there's a sense of how little could we get away with to get some good data. Whereas I would argue, like anything else, the more professional and better you can do it, the better data and the better your product and the better information you'll have. So objectives, understanding the different, how much things cost, and then planning ahead. Now, it used to be that things like ethics approval or IRB approval was a big delay. Currently in the UW, for example, that's not a delay. We've got a really slick system of IRB approval now, which is fantastic. That used to be weeks or months of headaches, but now it's really slick. But what often holds us back is the legal issues and agreeing contracts and terms, particularly when we've got the UW who's got many, many lawyers, and they're sitting on a vast, deep pockets, not wanting to risk that with a poorly thought out contract. So they're, and I would suspect that's the same with any large organization. Deep pockets means, I was going to say deeper lawyers, means probably more lawyers. And as a startup, I'm sure that's the last thing you want to spend your dollars on, hours of legal. So anyway, I think to some extent, when you can trust the UW's, in our case, business unit office to understand, the IP and the copyright and the usually the lack of interest in trying to steal those from you, from a state university, I think that's helpful. So I think third is the time and planning ahead. What other things come to mind when you guys have done successful pilots?
I can add a couple.
Okay. Yeah.
From what I've seen. I think what you're hitting on a bit is the importance of picking the right pilot partner, right? Not all partners are created equal. There are pros and cons associated with each individual enterprise pilot partner. So aligning what that partner values with what you're trying to get out of the pilot is critical. And thinking about, you brought up the lawyers and the legal piece, right? What's the goal of your pilot, and what's your highest priority to reach that goal? Is it data rights? Is it data use? So using the data that pilot customer may already have. Is it outcome measurement? Is it ownership of IP? Is it funding? Is it timeline? Is it scale post-pilot, right? So one of the issues that we see a lot of is death by pilot, right? So move from pilot to pilot without shifting from that pilot, even if it's successful, to an enterprise-wide deployment, right? Because that's ultimately what you're trying to create with a pilot, is the success metrics that ultimately lead to an enterprise-wide deployment, and then hopefully expanding that outside of your pilot customer. So what's important to you and what are you trying to get out of it, and then aligning that with your pilot partner. That's key.
And I think related to that is what's realistic. For example, right now, it would be quite unrealistic to expect that you could embed something in our electronic medical record Epic system at the same time that UW Medical Center is trying to bring Northwest Hospital on board in Epic. You can imagine the hundreds and hundreds of IT staff are like, just don't bother us type of thing. Mm-hmm. Whereas other areas, other clinics, there may be smaller clinics that may be more feasible. So I think being realistic about how much time and effort people might have to contribute is, particularly with the busiest of staff, whether that's the frontline clinicians, clinic managers, or the IT staff, whatever. There's often some trying to be realistic about that rather than hoping people will be jumping up and down with excitement when they're just trying to, I wouldn't say put out the fires, but almost, or in this case, kind of mop up the floods. They're just so overwhelmed with trying to deliver.
Yeah. And I'd say finding the right champion, you kind of alluded to it, right? There are lots of pieces of of these large organizations. Some are going to be a better partner for you than others, and they may not be the most obvious person.
Yeah,
right,
and
of what you're trying to accomplish, going back to your goals.
Totally agree. And even within the Seattle area, and we don't exclusively work with UW Medicine, I should point out. We work with multiple clinics across the five-state region. So we're not solely aligned with UW Medicine. There are some great advantages with UW Medicine and our clinics, and there's some disadvantages. Sometimes our smaller rural clinics are much easier to get into, and we'll hear later from Alison Cole, who runs a network of about 80 clinics across the region who take part in research. Hardly any of them are UW Medicine. So I think being aware of, are the partners in town, is it Swedish, is it Providence, is it a clinic in Yakima, who's a better partner? And again, I think it's just finding the right fit. So I think finding the right fit rather than hoping that the Swedish or the UW Medicine is the only place in town. Of course, we're
right. And then last one before, hopefully you guys have some perspective on this too. I'd say laying out a roadmap post-pilot up front, right? So agree on what the success metrics are, and if you do hit those success metrics, what happens? If you have the right pilot partner, they will have no problem agreeing to that, right? Where you start to get some concern is if you're starting to push moving beyond that pilot and you get pushback, you may not have the right partner, you may not be connected into the right piece of the organization to ultimately get to your ultimate goal.
Yeah, I think, and that brings up what we might call an evidence pathway. So a pilot study is just a part of that jigsaw going from bench to bedside, let's say, and it's often a different kinds of data, different kinds of information, different kinds of evidence occurring across different amounts of time, costing different amounts of money from tens of thousands to millions. So mapping out that evidence pathway, so the pilot study is part of that and is connected to it rather than being discrete or separate. So that evidence pathway or roadmap is really essential.
One related question, paid versus unpaid. So what I'm bringing up is, do you think innovators and startups should defer getting paid for a pilot to accomplish some other goal? How do you guys think about that trade-off between, and in some cases I've actually seen startups pay for a pilot, so the opposite, right? The startup pays to do the pilot. How do you think about that funding piece? I know you referred to it before, but let's unpack that one a little more.
Yeah, I think it would be hard for us to work on a pilot study that didn't pay for itself. That could be staff, it could be accessing records, the time and money it takes to do that. All these things have a cost, and nobody else is paying for them. So realistically for us in our organization, it's very difficult to do anything without external funding, whether it's NIH or foundations or industry. There's just no one else to pay the bills. So I think I think that's the reality. Some pilots cost more than others, and some organizations, companies have more. They're further along in terms of investment and venture capital than others. And I think some realization of that, so one is not being ridiculous. But I think, for better or worse, it just takes money to get people to do things, because otherwise they'd have other jobs. And with the kind of benefit rates and expenses we have at a typical university, even a entry-level researcher, by the time you add on a 30% benefit rates, it is costing a decent amount to do that. So I'd say we've not worked with any startups where we've been able to do anything for free, but I'd say we do tailor the budgets based on what's reasonable, and some awareness that not everybody's multinational companies have got different kind of dollar amounts than small startups.
Yeah. We've talked a bit about KPIs, or key performance indicators, or is what that refers to. Do you have a few examples of when KPIs have been designed in the past? What, in your mind, what makes a good KPI that leads to pilot success versus a bad KPI?
And in terms of, just explain this question just a little bit more. Just take me through what you're thinking about a little bit.
Yeah, so we've I think talked a bit about pilot success needs to have concrete measurement associated with it, an agreement on that indicator, if you will, for success. that's also a bit of a fluffy topic, I would say, where you could spend any number of hours and days arguing over how to design the right outcome measurement and agree on it.
Yep.
How do you kind of get through that as a startup? What is your advice on selecting the right things to measure?
Yeah, I think it gets back to what's the goal of this pilot study. Is it to demonstrate accuracy? Is it to demonstrate feasibility, usability? And some of these are much more numeric measures, and others can seem fluffy, like feasibility, but they can be measured quite quantitatively if you know how to do it. So I think trying to get away from softer, let's call them fluffy or not very tangible measures, to almost all of the things we've talked about can be measured, and there's often experts who've spent their entire life measuring the acceptability of IT type of thing, or personal smartphone adoption. All of the things you'd have no idea people have spent their lives and PhDs and careers measuring. There are often measures for these, but it's finding out what they are and how rigorous and valid they are, rather than just either guessing or just assuming you know and you just don't know. So I think those, but I think the other KPIs, thinking about the process measures that we often get bogged down on in terms of NDAs, legal sign-off, all of those things, which they're in the process and often quite tedious but important to get to the the ultimate outcome measures.
I think that goes back to what we talked about before around prioritizing what you want to own from the pilot study, right? And how that's going to help you commercialize your solution further down the line as you go back and forth on red lines. Know what hill to die on and what you can give on.
Exactly. So, for example, and I wouldn't want to appear to be being down on the UW. I love it there. I'm a professor there, and I've been happily back and forth between the UW and other institutions in the world. The UW does have for certain contracts, service contracts, they do have very generous, you keep the IP, you keep the copyright, we are just providing service to you. So they're not necessarily trying to steal everybody's IP. Now, if I was to invent something in my lab and try and commercialize it, well, there's other ways that they'd want their percentage or their royalties, but some of the work we do is purely on a service basis. We provide a service for you, and you keep the IP, you keep the copyright. And so those kind of contracts, if one can do those with a minimum of legal changes, are very smooth. When it starts getting down to the nitpicking of certain words and things that being paid within 30 days or 60 days or 90 days, the things our lawyers flip out over, it's just like, it's not worth dying on that hill, just type of thing. Other times, research is, as you move to bigger contracts, there's a little bit more in terms of sharing IP if we and you are generating IP together, but that's reasonable. I wouldn't want you to think the UW is unreasonable. They really do try and encourage these collaborations. As a faculty, I can spend a day a week working with industry. I'm allowed to do that with permission. So they do try and encourage and have a very generous way of us trying to collaborate with the community, industry, startups.
I have a question. So what is the value for a startup having a pilot for an investor?
Yeah, I think it depends on the stage of where the idea is and where the company is, but pilots are kind of the requirement for funding in some respects, right? And again, it depends on where you are. Like if you're pre-pilot, obviously it doesn't then, but once you're starting to create a product or service and trying to commercialize it, pilot is kind of that first test of the commercial viability of the product or service, and that's ultimately what investors will invest behind, the early stage ones. So it is pretty important. And then this goes back to what we had been talking about for most of the time here, the details of the pilot itself, right? And designing it in a way that ultimately you can show to an investor that you're on to a viable business model. right? Because that's what the investor is thinking about. Less so caring about data rights or data use. It's what are the KPIs? Is it clinically viable? Is it going to change physician behavior, right? Things can be economically viable, but they aren't necessarily clinically viable, right? And all too often those two things are linked. We can't forget that they're linked. But they're very important. I think we wanted to open it up for questions, but I had one more before we do that. Is there anything you think innovators or startups fail to address or think about when they're preparing to pilot? If there was like one example that we see a lot, privacy and security, dealing with PHI and being HIPAA compliant sometimes is a requirement even to run a pilot, right? If you're digesting data that is PHI, right, or personal health information.
Yeah, I think the thing that strikes me most is not understanding how busy everybody is in the healthcare system. And I know we say that, and you've all been to your doctor, and everybody's busy, but understanding those pressures of, particularly in competitive markets like this, or primary care clinics in the community who are struggling to stay afloat, stay in business. I think not understanding the pressures they're under, and the fact that they're largely delivering healthcare which is quite good, quite efficient. We're not in the 17th century. We're all delivering fairly good healthcare all the time. So that interest in changing or adopting or taking anything new on, that the appetite for that is really low, because people are just trying to maintain quality of care, access, all the measures that you get paid for, the reimbursement, stay in business. The medical assistant nursing staff turns over. My clinic at the weekend, we had a big flood at Northgate, so half the clinics closed. You can imagine those are the things. So trying to get in the door it's a busy time. So I think, and we'll hear later that there are ways of doing that. And Alison Cole is going to talk about some of the clinics in the community who agree to do research, but they're volunteers. They're not largely getting paid for this. So finding a way, a safe way, a efficient way of accessing, in our case, clinics, is really important. And Alison and others do a good job trying to curate and focus those down, so clinics aren't getting bombarded with lots of different, let's say, half-baked ideas, but just the ones that are likely to really be attractive and something for clinicians in the community to effectively volunteer to help with effectively. So I think that awareness of the busyness, the struggles, the measures that clinics are under to stay alive and survive and provide good care is where we, I think, can help to navigate that. Not that we can open the door to everybody, but at least help to curate your ideas in a way that's going to be palatable, not off-putting or unpalatable.
Yeah, I'd say knowing the customer is another way to put it, which is also critical to pilot success. So that's a good place for us to end. Happy to answer any questions. Yeah.
So how do you think of the value add that the lab brings? You've described the fact that you have an overhead cost that may be higher than other partners might bring to the table. Yep. But if I'm an investor in an idea and I have a pilot that's run by your lab, and that provides a cachet of confidence that if the results of the pilot are what we hope it will be, and you've certified that I have a better chance of then running the pathway to commercialization. And your value add then is the confidence that you give my product and my investors at this point to go to the next level. Is that how you all see it?
Partly. I think often we work with group startups because of they value our expertise, professional, and the name of the UW as a stamp of approval. And of course, we have to make sure that what we're producing is worthy of that. But and the UW and most other places have got different ways of calculating indirects. So, for example, from charitable foundations, it's very, very low. NIH, it's much, much higher. Industry, sometimes it's in the middle. And indirects aren't profit. They're just, paying for the lights, the building, probably the stadium. But no, sorry, probably the stadium pays for the rest of us. Thinking about income from football. So I'm not sure if that answered your question fully. Yes. Yeah.
Hi, I'm Victoria. I also work at PCI Lab. So one thing I think we've seen in pitch decks and in proposals before is that organizations may have done some sort of pilot in-house, but they don't seem rigorous enough, and it's not going to carry weight when we approach health organizations. So can you talk about what that's looked like and maybe how we make sure there's more rigor?
It's not fair, my own people asking questions. And no, Victoria's great. If feel free to talk to Victoria as well about ideas, and if you want to meet us. Yes, I think I spend vast amounts of my life thinking about how to generate data. Could be qualitative, quantitative, with different ways, different mechanisms. That's what I do, and I spent decades doing exactly that. So that's my expertise, whereas you, as I mentioned, you could be a software or a hardware or some product design. That's your expertise. So I think the key thing is trying to tap into our brains or my brain or my colleagues' brains to figure out, I want to measure feasibility, acceptability of this. How do I do it that's the most rigorous way? Because there's, like anything, there's ways of collecting crappy data, whether it's an opinion poll or whether it's someone's opinion about something. And there's good ways of doing it. Often it's not the money, it's just the thinking that goes in rather than just a slapdash, unprofessional way of doing anything. But I think it's no different to if you had product design. You could have something that designs really well and something that's designed really badly, and you know which one is going to have most weight when you go to your investors or start selling something.
Just another way of also saying KPI design is incredibly important, right? And as you think about designing KPIs, think about the end goal, and those KPIs should be valid enough to get you to that end goal.
Yeah, absolutely. And yes, and I think the other thing sometimes we do see ignored is that there's often a wide, broad, large literature on what you're working on, and there are some very sophisticated, formal ways we can do that. A couple of years ago, we engaged with a company who was making keyboards for the medical office that would sterilize themselves with UV light. Kind of really interesting. So doing a systematic review of, well, how often are keyboards contaminated? What are they contaminated with? How bad is it? That took some time, but then we could show almost every keyboard in a doctor's office is contaminated, and maybe 1 in 3 with pathogens like, C. diff or MRSA or that kind of thing. That kind of information for an investor could be really useful to say, wow, there's a massive market for a product and nobody else is making something. But that would be quite hard for the people that make keyboards to actually come up with that in a rigorous way without just having a quick search on Google, which wouldn't be enough. So we found dozens of articles which backed up their case. I think sadly they went out of business, but never mind. Sorry? Disposable keyboards, or no keyboards at all, and just speaking into the device. Yeah. So question is, if we don't work with products sold more direct to consumers, I'd say less of that. we're working currently on a study, and there's a lot of FDA interest in this kind of study of individuals testing themselves for flu. There's likely to be a whole new era of tests, just as you go to the pharmacy and buy a pregnancy test, or you buy a blood pressure monitor or a glucose monitor. There's lots of interest in commercial companies and others in direct-to-consumer testing for many other pathogens. Think about flu, group A strep, think about sexually transmitted infections. And that's exactly where not just test accuracy, but the acceptability to the consumer and all of the issues of different ways of designing the product and the app that goes with it are absolutely. But other than that, not so much. I wouldn't say we've got so much into direct-to-consumer types of health products.
Yeah, thanks for taking my question. So just a question on the portfolio of your pilots. Are your pilots mostly in pre-510K stage, or do you see companies that, let's say, have an FDA approval for a product and are looking for some commercial catalyst to get to market, or they're already starting to commercialize their product?
Yeah,
Do you see pilots in that category as well?
Yeah, I'd say both of those. And the FDA approval is quite a low bar for us in the clinical world. I realize it's a definite bar to be achieved, but in the clinic world, we have had experience of doing work with products which are FDA approved, but failed quite substantially, even with a small pilot study. And that led the company to really rethink their strategy in a positive way, just thinking, okay, it's not going to work for that, but it could work for this. So it doesn't have to be a negative thing. It can be just be a redirection. But FDA bar is often, particularly for devices, diagnostics, is quite low. Different for drugs, of course, and vaccines. But technologies, often a low bar, and in itself, rarely sufficient to start selling, rarely. Well, so where is the failure? Well, each country has its own kind of regulatory bar. FDA's has been higher than the Europeans, although that's changing. That's changed quite recently. You think about the average medical device, the median number of research studies prior to approval is 0. So a new hip replacement prosthesis is approved based on a predicate, based on a predicate, based on a predicate. So, and that's where we've come to fail with certain implantable products where we see the risk. Of course, the ones where we see less risk are things like thermometers or glucometers or different kind of lower risk medical devices. But it's a good question. It's a great question.
Matthew, can you repeat that? You said that.
Yeah, the median number of studies for, and we published this a few years ago, the median number of studies for devices is 0. So most devices do not get approved based on vast amounts of clinical research. So you can imagine why some clinicians are a little bit reluctant to change practice, because they may say, hey, you've got a new knee replacement. Where's the evidence for that? It's like, oh, we don't need any. It's FDA approved. It's like, okay.
That's interesting. That's interesting. All right. Any last couple of thoughts for the audience here before we end? All right. Join me in thanking our panelists, Kurt Scheelein and Dr. Matthew Thompson. We are going to get started here. Welcome to part 2 of Cambia Grove's Fall Kickoff, where we are officially launching the Trails competition. Woo! All right, so Fall Trails competition launching today. For the Falls Trails competition, what we are doing is something a little bit different in that we are going to focus on seeking solutions that address a specific pain point in the primary care practice. Specifically, our challenge statement is that pain points that clinicians face in their day-to-day work include inaccurate data and inconvenience of additional steps as they interact with various technologies. This Trails competition seeks solutions that improve the accuracy and efficient use of data to improve clinical workflow and patient engagement. Now, the Trails competition is a little bit different than your typical competition that you see in the startup world. Instead of receiving funding, startups receive the opportunity to have real-world access and testing of their applications in the primary care clinic for this specific competition. Specifically, startups, depending on wherever your startup lies in the commercialization process, you have the opportunity to work with Dr. Matthew Thompson and UW Medicine's primary care innovation labs for up to 6 months. So this is really pretty exciting. Our last competition that we did, where the prize was working with children's hospitals up and down the West Coast, one of the women who hosted Brainchild Technologies, who won, said, there really isn't any other prize out there that's more valuable than having this access and testing in the real world. So we are thrilled to be partnering with Dr. Matthew Thompson and his team at PCI Labs, and are very excited to have applicants from really around the world who can address the specific pain point. Today, what we're going to do for the next 30 minutes or so is have this distinguished panel discuss the pain point and discuss the Trails competition and how startups can really have an impact on this pain point that we're facing. So with that, I am going to turn it to the panel to introduce themselves and talk a little bit about their work. Now, Dr. Thompson, we just were able to enjoy the Lunch and Learn series, but it would be great for you to have maybe touch on it for about 3 minutes or so on what you do and why this competition is exciting.
Yes, no, thanks, Maura. So, as we mentioned before, in the PCI Lab, we try and bridge the gap between entrepreneurs, startup industry, and the primary care clinical and research world, particularly to try and generate evidence that something works, it doesn't work, it's more efficient, quicker, cheaper, nicer, that kind of evidence. So specifically for this competition, and Alison will talk with us in a second in terms of this being a need that our primary care clinicians have definitely identified, and one of the major contributors to physician burnout. That is really some scary levels of clinician burnout going on, and probably every industry there's burnout. Teachers, anybody. But it's nice, important, essential to think of ways of combating burnout. So I'm hoping this competition can be part of that. It doesn't seem to make sense that nowadays I spend more time looking at the computer than looking at the human patient in front of me. There's something wrong. Something's gone wrong there. So specifically, what could we offer in the PCI Lab to the winner? I think there's several things that we can offer, and several things that probably not realistic. We were just talking about pilot studies earlier. And Victoria, just give us a rundown of the 3 or 4 things or ways that we could work with the winner here. Sorry to call on you.
Yeah, as Matthew said, it really does depend on where the company is and what the product is. So the first option is usability testing, said with 5 to 10 clinicians, and this is if you really want feedback. We're getting in the weeds, experiencing the product. Sometimes, it sounds great at a high level, and then as soon as they get playing with it, they can identify pain points really quickly. So that's the first. The second is development of an evidence generation plan. So as Matthew talked about in the first part of today's event, we can come up with a lot of different types of studies that can be done to demonstrate the value, the the scale of the problem, what's been done to date, and help companies then prioritize which studies need to be conducted to work with their partners. And then we have a detailed literature review also, which can be one form of evidence generation to see what else has been done to date, competitors, that kind of analysis. And then the last is shadowing of clinicians within either the UW system or within the WPRN network.
All right, fantastic. So WPR network. Allison, what is this network and what does this competition mean potentially for this network?
So thanks. I'm Allison Cole. I'm a family physician at the University of Washington, and I'm director of the WWAMI Region Practice and Research Network, which is what we call the WPRN. And this network is a network of about 83 primary care practices across 5 states, Washington, Wyoming, Alaska, Montana, and Idaho. And the practices collaborate with us through a coordinating center that sits at the University of Washington to conduct research that's important to primary care practices and improves primary care practice and the health of patients and communities. So this is a really robust and large infrastructure of primary care practices that are committed to research and health innovation, and we have an infrastructure that allows us to collaborate with investigators, and we're a partner in the PCI Lab, and so investigators and teams that are working with PCI Lab have the opportunity to work with WPRN clinicians and practices. So depending on what your product is or what your innovation is and the settings in which it could be used, the WPRN might be a great setting to do your work.
Fantastic. And Dr. Bob, so the pain point, that challenge that I read came from the WPRN clinic or the network. It was people who selected that as one of their top pain points, and we were able to narrow it down to that specific challenge. Dr. Bob, give us a little bit of idea of how this challenge, of yourself, and how this challenge, you see this challenge potentially having a impact in primary care.
Sure, gladly. Pleasure being here. Just quickly, my background: Bob Crittenden. I did a lot of senior policy roles, both federally and statewide. Practiced for almost 40 years, and now working with the Cambia Grove here, and really focusing on how we actually improve and change the health system. I think I am the neighborhood curmudgeon about a lot of change in one way, in that when I was practicing, I was just mentioning this, that we had so many times that new ideas, new drugs, new everything came out that were about a year later rolled back and taken away, and people decided that it was dangerous or wasn't really well tested or anything else. And so I had a kind of a general strategy that I waited a year after something new came out before I ever would think about it. But once I had some experience, I would, and it looked good, then I would do that. Now the problem with that causes very slow change, but in some ways it's actually good for the care of the patients. You know, prima non nocere, first do no harm, and we do it that way. But I also see the health system is just dying for huge changes. I mean, one of the things that killed me, I did a fellowship in Norway in 1974. At that time, they were implementing evidence-based medicine, team-based care, community outreach. I mean, everything that we're talking about now, they were just finishing up the implementation of at that time. And you realize that as a country, we're way behind, not just in primary care, but in a lot of our delivery mechanisms. A lot of things we do are wonderful here, but a lot of things just haven't cut it. So my interest is really in figuring out how we get change in place and how we actually make changes that make a huge difference. And I think we need a system as well as a gizmo. You know, we need the things that we want to change, but we have to have a system that they stick to. So now, when we talk about all these things, when you think about a pilot, or any kind of study, I, as a physician, really want to know, is this going to really make my patients better off? What's the cost implications? And lastly, most importantly, since a lot of things have changed a lot in my experience over the last, say, 15 years of practice before I stepped out of it, was, is it going to just kill me off lifestyle-wise? I mean, lifestyle at work. I'm not talking about home. I'm saying, how can I practice efficiently, effectively if I have to do that much more? Quick example, 3 EMRs every time I was less productive, each time we made a change. I mean, how many patients I could see, how much time I spent. And it was measurable. I mean, it was a very measurable thing that was real. And I think if you're trying to do something to put something in place, you want to think about all those things. We want better outcomes, costs at least the same or less. And if you want acceptance, you have to make it so the providers want it.
So those are great insights. My next question, and to be clear, this challenge, when we say we're seeking solutions, we're not seeking one type of solution. We are solutions agnostic at Cambia Grove. So your solution could be a technology, your solution could be a new process, or a workflow type of solution. Your solution could be a new communication method. Lots of different opportunities in that. And so my next question, and then I'll reread the challenge statement just so everyone's thinking through this, is what types of solutions have attempted to solve this pain point? Or have you all seen anything over the last couple years or decades that is looking to address this very serious pain point? Pain point being that the pain points that clinicians face in their day-to-day work include inaccurate data and inconvenience of additional steps as they interact with various technologies. The solutions we are seeking are those that improve the accuracy and efficient use of data to improve clinical workflow and patient engagement. Now, are there things that we've seen that try and address this, or are we at the point in which we've realized that the technologies that clinicians are interacting with have come to that quote-unquote tipping point?
Well, I think one of the things that I've observed is that there have been increasing innovations in displaying data and reporting data to clinicians at the point of care, and also in a population way to manage populations of patients. I think the challenge has been that the amount of data that clinicians receive just continues to increase. And so the technologies to share that data and report that data and give that data to clinicians in a meaningful way seems to be moving more slowly than the amount of data that we receive and the amount of data that's available. So it's not lack of data availability that's the problem. It's understanding efficient ways to get that data to the clinician at the moment that the clinician needs that data. And increasingly, we're receiving data that's maybe tests that have been ordered or information that was entered by a clinician at a previous visit, but there's also patient-generated data, wearable data, and data that patients are collecting themselves and wanting to share and integrate into their healthcare. So there's a lot of different types of data, there's huge amounts of data, and so I think even though there are tools to interpret that data, it just isn't keeping up with what we have.
I'd say I totally agree with you, Alison, and it's both the data input and the data output. In terms of data input to the electronic medical record, the thing I've seen that's made a huge difference recently is, Dragon dictation, which I can speak quickly, much more quickly than I can type. But that kind of thing has made a difference, but it's still not enough. And there's, with us all using Alexa or Siri to do many voice-controlled things, I haven't quite seen that yet in the medical office, although that's coming. So data entry is one, but I totally agree with Alison. The interface between the doctor and the information is very crude, and many things are being missed in terms of bad things in the medical record, things that are overlooked, you just can't see. Sometimes I can't imagine what it's like being a pilot and flying a plane, but it's almost like you're getting all of the data from all of the engines all of the time, every minute, and you're like, I'm just trying to drive the plane in the right direction. So things do go missing, and things do go wrong, and we miss things or repeat things. So now in our Epic system at UW, I can look at someone who's been to Swedish, been to Providence. I can look at everybody's record, wherever you've been, and trying to integrate that in a 15-minute visit where we would probably spend about 60 seconds trying to absorb all that information, then see the patient, and then write the record, billing, coding within 15 minutes. So pretty much that information digest has got to be within seconds or a minute or two, because that's all you've got. So I totally agree, that interface of the data and how it's appeared is very, very crude compared to what we see on other things in society and in life.
I'd like to make a comment. The question was what changes have made a difference in this. And one thing we did, when we were at Harborview, we went to a team-based approach. And the reason this is valuable for information was that instead of requiring the doctor to do everything, we had pharmacy reviews by the pharmacist who would, sometimes with diabetics or other people, would review things before we saw the patient. The medical assistants did all the prevention work and review all the data before we saw them. So we could get at least a lot of the things out of our heads, and we could concentrate on, say, the behavior change or the diagnostic issue at hand. And that isn't a technical solution, but it just gives you I think it's a good concept to think about, that we try to funnel all this tons of information through one person, which may not be the best way to do it. It may be better to have different streams, like through different people, or have it in, really bring it down to those key issues that the doctor needs to know in a handy way. It'd be nice to push the button and have a thing pop up and say, this guy has diabetes, he has this is what, and this is the background, and here it is, and it's a little red, a little green, or whatever. Something that you can look at pretty quickly, so that when you get the information, you go in and actually talk to the patient, which is probably the most important thing we can do.
Now, I love this comment because it opens the box of thinking on what potentially folks could apply with, what kind of solutions that they could apply with. It's not just the interface between the EMR and the doctor. Maybe there is the opportunity to bring in that team-based approach. Are there any, and I'm putting Dr. Thompson, Matthew, on the spot here, are there any guardrails that people need to think about when applying, that they should kind of sway from, especially in the workflow or the offering of PCI labs?
That's a good question. I think we do have to be careful about not offering too much. I mean, this is a highly valuable, but a short-term and tangible engagement, and we would absolutely not want to say we're going to open the doors of all of our clinics or Allison's 83 clinics, that you're going to be just in there from day one, fiddling around with the medical record. So I think there's some caveats about what is realistic for a kind of a reasonable engagement in terms of accessing, doctors accessing some of the systems and or staff and patients. Now, what that is, I think, as Victoria mentioned, we've definitely come across cases where a device, a technology, a thing looks amazing in the lab, but faced with just some ordinary clinicians who are interested in change, but they've kind of torn things apart within seconds. And that kind of thing, you don't want to miss that, because it's just such an obvious problem that's going to appear as soon as you start marketing. So I'd say realistically about how many clinics, for how long, and how deep into, let's say, the IT systems. Those are often very, very difficult departments for us to either penetrate or work with, just because they're so busy. That's my thoughts. How about you, Allison?
Yeah, I would agree with that. I would say that modification of the EMR system is going to be a huge challenge, and probably not very fruitful for changing clinicians' life. So that might not be something that at least I would encourage, but I think, yeah.
And let's say you had a new EMR interface. It could be that you don't actually have clinicians with live patients. You could say, here's a standardized patient. What's going wrong? Where are your eyes going on the screen that would be better to focus you? So that kind of thing with 10 or 20 clinicians or types of patients, that kind of thing. Then you could say, aha, here's what we need to develop more of, to an interface that brings the blood pressure and the vital signs or the diabetes numbers together, that kind of thing. I think I would also say Alison and her group at the WAMI Practice-Based Research Network have a great way of curating and focusing attention. And if you work with Alison's group, they have a one-pager I mentioned before that lays out in really simple terms what's in it for the investigator, let's say you or us, what's in it for the clinic, what's it going to take, in very ordinary words that everybody can get on board or not. And when you send those out, you've curated that information so that there's no missed expectations. And almost always clinics put their hand up and say, yes, we want to take part, because you curated it quite well, I think.
I think for the WPRN, we have a very structured process for matching projects with sites. And so getting partnered with PCI Lab is a great first step in building a partnership with a WPRN clinic, but it is not sufficient. And there will be additional work to work with our coordinating center and our steering committee to develop your idea and make sure that the clinics are on board and are getting the resources that they need to do the work, and that there's benefit for the clinicians in the clinic. So we really are enthusiastic about supporting people in doing that work, but there definitely is a process, and it is very bidirectional. Our clinicians are volunteering their time and their energy for this work, and they need to feel like they're partners in the process. And so bringing them into that partnership is also really important.
So we know this is a pain point. WPRN, PCI Lab was able to help us craft this challenge. Bob, as you mentioned, you would wait a year to see if things actually worked and panned out before you would take that risk and bring on some a new solution into your clinics. Are there things, because we know this is a challenging pain point and we know that something needs to be done, are there things that startups who are looking to apply should be thinking about to de-risk the, or even to be able to catch the attention of some of those folks who might wait a year and maybe hopefully be able to reduce that?
Yeah, absolutely. I was just thinking about that while you were talking, is if I were putting something together, the first thing I would do once I had a good concept and clean and everything is to spend a little time listening to people. What, does this fit? Does it work? What can I do differently? And it's really a highly qualitative research, if you want to call it. It's really saying, let's have focus groups, but you can never get doctors to go anywhere, so you almost have to get them on the phone or find time at some weird time of the day to talk to them. But to really listen, to see, here's an idea, or make it show them, go see them, or even a few people where you actually have people who are actually working. Is this something that's really going to be helpful to you? And if it was more, could you change it in some way to make it more helpful? And you could fashion a lot of things. Now, if somebody came to me and asked me, and this has happened, where they say, what do you care about? And then they adapt something and make it so it works, so it fits my little, they'll say the plug fits the socket, well, that I would be much more interested in getting involved in it. If it's coming out of the blue and I have I haven't thought about it very much, it's a little harder to get engaged in that. But I think what I found on my research side, which I did a lot of as well, that if you listen to people, you actually learn a lot and you actually adapt things, and if you adapt them to the right way, that you'll find that people are kind of general. Like I probably represent 10,000 doctors around the country, in my attitudes, and you get 10 of them, you probably have 100,000. I mean, you're getting to a place where you can get some information. So first thing is really to listen and figure out are you really doing something that makes a difference that people like and want.
That's great. I'm going to ask one more question, and then let's open up to Q&A from the audience. Anything you all need to or are interested in knowing about the competition or this pain point. Infrastructure. A lot of what Cambia Grove does is tries to look at system-level barriers that are preventing innovation from flowing freely. And the trails competition comes directly from that work, and that there is not enough opportunity that we see there's not enough communication between startups and the 5 points of healthcare. And so the Trails competition was designed in a way to enable startups to get that feedback from the healthcare system. While there are infrastructure barriers, especially around data, we think about HIPAA, we think about PHI, there things that, and we know that things are changing with the federal government's ONC rules and different shifts in those policies. But thinking about this competition specifically, are there things that either are no-goes or would present themselves as larger barriers in addressing this challenge? Again, on the spot.
Question.
Yeah.
I think one thing you mentioned is data. I think it's quite difficult for us to share our anonymized patient data with external groups. I mean, it's highly valuable, highly regulated. It's relatively easy for me to look at and do research with our data warehouse, with our millions of patient records. It's become much easier recently. But for obvious reasons, there's reluctance to share that with commercial groups, both for data security and for ownership reasons. So I think data is one. Of course, we could imagine a study where you're interested in, well, how many people get an echocardiograph done? And we could look at that within our data sets ourselves and give you here's the summary, here's how many, from what sites, and what age, and what comorbidities. But it'd be quite difficult for us to just give you all that raw data. So I think that's one that comes to mind. There's probably others.
I mean, I think that we have done all sorts of projects and all types of work in our network, and in some ways, there's nothing that can't be done in primary care. I think the constraints of this are the time frame and the budget, and so I think it's important to acknowledge that working with clinicians and primary care practices takes time and money, and so knowing that is important.
So if it's a big project, this could be the first step in continuing that project moving forward. All right. Questions from the audience here. Let's go here first. So, actually, we do have a mic, so we are recording. Fantastic.
So one of the questions that I have is, how many patients are the primary physicians required to see a day? Because a lot of the times when you talk to primary physicians, they'll tell you, I know what's going to happen is happening in the business part where you were just bought by such and such. I just know I have to see 35 to 40 patients. So how many patients are they required to see? And what is the staffing like? Do you have RNs in the staff? Do you have only assistants? Because the nurse assistants, they're very helpful to do blood pressures and and the really minimal things, but they're not RNs, and they don't have a clue about a lot of things. So that doesn't necessarily save time for the physicians. Sometimes it creates a lot more work because they have to, they cannot rely on the nurse assistants. They have 9 months of training, and they have very little medical knowledge.
So the question is, how many patients does a physician have to see, and what does the team look like?
I can answer that question on behalf of the WPRN practices, which is to say there's huge variation. So we have 83 practices. They're all part of different health systems and organizations. Some of them are independent primary care practices. Some of them are part of hospital systems. So they all have different patient volumes and different organizations. So there's no one answer to that question. And I think the ideal solution would be adaptable to work in different types of clinical settings and different types of organizations.
All right, and as we go to our next question, which is right over here, Dr. Thompson, can you give an overview of WWAMI, Washington, Wyoming, Alaska, Montana, Idaho, and what that means?
5 big states.
Yeah.
Yeah. So the UW has been, proud to be has been the only medical school for the 5 states, covering 27% of the U.S. landmass. Well, I believe a population of 10 million? Is that right? Just an interesting factoid for you. We send medical students out to do clerkships at clinics around the region. From the westernmost clerkship site in Alaska to the easternmost is, guess how many miles? I think it's 2,000 kilometers. It's the same distance as London to Moscow and back. So we're a vast medical school across the 5 states. Of course, we now have a new medical school partner in WSU, and osteopathic school in Yakima, Pacific Northwest University. So medical training is expanding, and I think that's a good thing. We also have, just in our specialty of family medicine, we have how many residency programs now? 22 residency programs training the residents with about 600 residents. So think many of Allison's sites also train residents, medical students. So there's a lot of overlap of medical school, residency, research, practice going on.
So lots of variation, lots of opportunity, lots of different.
Yeah, I mean, I think the opportunities that I would highlight that are part of WWAMI are the obviously the geographic variation and the fact that it includes urban regions and suburban and rural communities, remote communities, lots of different types of health systems. Because you have 5 states who have different state policies, you have the opportunity to look at the influence of state policy, whether they expanded Medicaid or other different policy decisions across states. So I think there's a lot of exciting opportunities because of the WWAMI partnership. Obviously, going to different sites and doing in-person work can be logistically and financially challenging. So we've actually developed some creative methods for doing research remotely to try to minimize travel costs, and our sites are really used to that. And I think it's really important when you're based in Seattle and you're used to working in Seattle to realize there's a big world of healthcare out there. And there's a lot of exciting and innovative things that are going on outside of Seattle, and this is an opportunity to learn from that too.
Fantastic. All right, and the competition is open to people around the world. No, you're good, but that's that. I just want to make sure everyone understands. Question.
Yeah, you said about the clinician burnout. Is that because of the data overload, or is that because of they don't have enough support, or is it because the patients coming from the patients?
It's a good question because I've worked as a family doctor in the United Kingdom and United States. United Kingdom, there's no issues of insurance because everybody has free access, but the burnout rates are even higher there. So there's something common going on. I think it's a combination of more patient demand, sicker patients with more diseases all at the same time, and more work that used to be done in the hospital now being done in primary care and outpatient for good reasons. And I think higher demands. People want more, they want it quicker, and they want it now. We all do. And I think the consumer expectations, just as we've seen for banking, for buying a car, for many other things in life, we want from our healthcare systems. Yet at the same time, we're constrained by dollars or pounds or euros. We're constrained by dollars. There's a loss of control. I think physicians feeling they're not in control now. They used to be. Now someone else is their boss, the manager, the payer. So that loss of control and less of what they like to do, which is seeing patients, looking after patients, and more of the stuff they hate to do, which is paperwork, bureaucracy, stuff in front of the computer. So that's my perspective, but I've seen it in multiple nations now.
Yep. Just also an expectation that you're evidence-based, that you're up to date and everything else. I hate to even think what it was like when I first started practice, but nobody ever saw a note I wrote. I mean, nobody knew what I did. I mean, there was.
You did fine.
Well, a few people lived through it, but now every time you do something, everything in. All to the good, and I've been very much a proponent of, is we have evidence, we follow protocols that are proven to make a difference. We get measured in outcome measures. We do, so it's what you wrote in a note before was, a couple lines. I saw a person with a little heart pain or chest pain, and we felt it was an MI, here's the EKG, blah, blah, blah. And that, it wasn't like really detailed. And now you have to have a very detailed note. People look at it, they make sure you're doing the right thing. It's much more stressful in that sense. And I think rightfully, we're much more, we're going that way. But I think what we've done is we have the same, besides a little EMR, where there is some real benefit to the EMR, even though I complain about them, but I think there really is a huge benefit. But even with that, we haven't made the substantial changes. Like in airplanes, they have they actually get it down to where the pilot doesn't really fly the plane too much. They have to make sure they're for problems, but they have a lot of other stuff doing other machinery, computers doing a lot of the thinking. We have basically taken the idea, well, we'll just take all this information, we'll shove it at the doctor, and we have this control board panel, which is just a bunch of numbers about 20 feet long. And you have about a minute to read it all, and it doesn't really work that well. So I think the stress is over, having higher standards, a lot more. You mentioned information that you have to sort through and you're responsible for. And then you have higher patient expectations. So it's a combination of things.
So a couple more hands go up. Jessica, there's one behind you. That hand's been up for a little while.
Thank you so much. So one of the biggest things that I keep hearing from physicians, PAs, midwives, et cetera, is on the burnout is exhaustion, is the length of the length of the shifts, the level of just and the amount of hours that they're working without any rest, and even though obviously there are on-call rooms, and that is one of the things I keep hearing a lot. Definitely, the time it takes them in their exhaustion to do the records and all those sorts of things are, of course, but that's something that really, when I'm thinking about a solution for this, that's something that kind of holds me up, because that's not something that we can create an invention that they can magically sleep while they're helping patients. But I just wanted your guys' thoughts in terms of the variation of shifts that exist, and the level of exhaustion that exists in this field, and at the different levels. Obviously, I know as a fellow and a resident, it's very different than a physician, but just wanted your guys' thoughts on that, as that is something I've consistently heard as I've spoken to many people in the healthcare world, is just the pure logistics of the industry, especially if you're in a hospital setting. So.
Yeah, I mean, I think in primary care outpatient settings, the shifts probably aren't obviously the same as in a hospital setting. I think one of the changes that we've seen over, and Bob can probably speak to this more over his career, but is patients' expectation of access for primary care is that they want to be able to see their primary care provider at a time and location that's convenient for them. And so that means offices that are open into the evening and open on the weekends and stuff like that. So you do see, even in outpatient primary care settings, clinicians working hours that might not have been a typical workday in the past. I do think that there's always been a culture of feeling exhausted in medicine, and so it's my suspicion that that's not new, and that probably won't go away. That's just sort of something that gets handed down over generations between physicians. So I think there's a little bit of that culture of exhaustion too.
The increase in time for, at least on the primary care side, has not been in the clinical time, the actual time in the clinic and seeing patients. It's usually the wraparound time, preparation, and really the record. And the changes, it used to be primary care did a lot of it more inpatient. About 20% of the work was inpatient, so you ended up going to the hospital early, then you see patients, then you'd go in the hospital on their way home. Now, I just, talking to the physicians I worked with, but also looking at the data, people spend hours after work trying to fill out all the charts. But you're also bringing up a lot of other, the nursing issues are huge as well. There's a lot of extra shifts and stuff like that people get shoved into, especially in the hospitals. I think nursing in clinics is a little more reasonable because they usually are on an hourly basis and get out the door. But I think that the whole you know, yeah, to a certain extent, it's been pretty busy all the time. You know, even back years ago, people worked long hours. And I think there's a difference also in expectation of what you're supposed to do as a doctor or a nurse now. You know, in the good old days, you're supposed to be dedicated to give your life to medicine, which meant you start early, work late, and your family never saw you. And now they can see us because they can see us through the door while we're filling out the doing the EMR at nighttime. But it's still probably about the same amount of time.
All right, next question.
Is working with the PCI Lab in some fashion a gating condition to working with WPRN, or are there other pathways into working with WPRN?
No, I think Alison and I work very closely together. I mean, our offices are literally next door to each other. Some of our projects, we work with other clinics, some with WPRN clinics. So I think we're flexible. Alison mentioned they do have a very good curating system, and it's not a barrier. It's more just to make sure everybody's on the same page. And I think it works quite well, and it's really efficient. It's not waiting years and years and years to get a response. It's kind of collaborative and helpful and formative rather than a kind of official bureaucratic barrier. So does that help? Yep.
Time for 3 more questions.
So this might be pretty obvious, but what's the financial cost of burnout or other costs, social?
That's definitely been studied. I don't know the numbers off the top of my head, but physician burnout is definitely associated with increased turnover and open positions and lower quality of care. So definitely increased cost.
Early retirement, shifting from fuller time to part-time, maybe not coming back after having a family, that, let's say, lost to the workforce. And I think that's both physicians, PAs, nurses. I mean, it's across the board. I've read something just earlier today, then I think they're predicting 120,000 doctor shortfall in the United States. And this is a country with very, very, very well-established medical system. In the United Kingdom, where I worked a lot of my life, expecting a massive shortfall as the European Brexit thing happens and there's less immigration from India, Pakistan, and Africa, where we used to have a lot of doctors. So even our high-income countries with really well-established systems for doctor training, not even think about nurses, which is maybe just as bad. So burnout just cuts into that workforce numbers yet again. Correct. In fact, there's some great scoring systems of burnout scores, which measure things like depression, burnout, unhappiness, suicide, drug abuse. Yeah.
So definitely a real topic we're getting into. Next question.
So just to stick with physician burnout and to complement it with fatigue by patients as well, with the inability to be able to navigate the healthcare system that we have here based on the kind of infrastructure that creates barriers. I'm curious, Eric Topol, the cardiologist, I think has made some really salient points concerning AI and the kind of information that patients are able to now, or individuals are able to gather, but then they bring it to their physician and they go, okay, how does this apply to me? So in my mind, that's just a whole nother layer of that frustration, of that information overload. I'm just curious if you've seen any kind of innovation, especially in this region, that's able to, I'm not, in my mind, I'm like, ideally there'd be a dashboard or something that'd be able to help physicians process that. But it's the other challenge to it is you take Veritas Genetics or those kind of companies that haven't truly been vetted by the medical community in a way that's truly applicable. So I'm just curious, how far away are we from, getting to a point where we can all work together and help support the community?
I think it's an excellent question, and I think in terms of area of innovation, it would be really fascinating to see applications around that. There's been isolated things, for example, people monitoring their blood pressure at home and bringing in different ways of averaging that have been, in fact, showing to be more useful than doctors measuring blood pressure in your clinic. And that's one little example, or diabetics measuring their glucose at home, very, very useful for adjusting insulin. In fact, that's the only way we can do it rather than some number we get in the office. So I think there's isolated examples, but they're quite isolated, and we've not created that system for all of the other data points in someone's life, their exercise, their eating, their mental health, their interactions, their falls. All of that is missing, and we've got very little silos of smoking, not smoking, type of things. And we don't have a good way of absorbing all of this data that we know is probably being collected on our smartphones and all of these things at any one time. So I'm really interested to see what happens. And as Bob mentioned, not just that you can do this, but does it make a difference? Because there's one thing to saying, look, I've curated all of this information about my genetics, my activity, my diet, my this, and how many times I went to yoga and Whole Foods. But if it's not making a difference, then it just becomes more noise, and there's no signal. It's just more noise in the system.
Time for one last question. I think we are right here.
Thank you. I guess kind of a comment and a question, I guess, is that given the importance of burnout, I guess I wanted to point out as a physician myself that there actually are, a lot more information available about it. It really wasn't talked about until maybe the last 10, 15 years or so. So both the American Academy of Family Medicine has information about it on their website, including they just had, I think, a wellness conference that was a few months ago, if memory serves, in Florida that was talking about kind of the aspects of burnout. But I guess if you're going to look into interventions for the trails competition, it's important to kind of look at, I think, some of the larger players and certainly the definitions, because it is complicated. The American Academy of Family Practice may be a resource if you want to get more information about it. I know that there's another provider, Dyke Drummond, who also had been working quite a bit on his own work on burnout and has published several books on the subject and still does quite a few talks, seminars. He's worked with Kaiser in Southern California and lots of health systems, educating systems and leaders about burnout. So there are some resources out there. I guess a lot of it also goes back to, I think, research by Maslow about the hierarchy of needs and sort of how that, I guess the mismatch between needs and locus of control can, put you on the path that, people would talk about burnout. So there are some resources out there. So certainly if you want to, I guess I would just say as a physician, if you want to really get into this competition, you really do want to educate yourself as much as possible so that your interventions can be best targeted. I think a lot of people would love to just throw money at it or hire more docs or have people work less. And if you do the research, you'll see that taking time off, taking vacation, doesn't usually address the fundamental issues with burnout. So as Dyke would say, it's not necessarily a problem, it's a syndrome. And problems have solutions. These kind of syndromes, they really need more targeted interventions, not a one-time lecture on burnout, but making fundamental changes kind of in how the system functions so that certain ongoing causes are addressed, not necessarily having a lunch where people can complain for a half hour about the MR and then go back and assume that since people were given a chance to talk about it, that they won't mention it again. So be careful, I guess, about your interventions as you go through in the competition and try to look at some of those resources. And I think that will hopefully give you a better sense of maybe of not just the scope of the problem, but usually I think the fixes are going to be fairly complicated, really, and probably things that need to be done on an ongoing basis rather than a one-off kind of solution.
Thank you. Thank you for those insights. So as we close today's panel, Dr. Bob, any last thoughts? And then Allison and Dr. Thompson.
I think the comment just made actually is really wise in the sense that we really make sure, we're talking about burnout, but we're talking about data, we're talking about a lot of, they're both fairly different in some ways, but they're really interactive. And I think it's worthwhile figuring out where the pain points are and making sure we're addressing those things. And the other comment was that we're all living in huge systems in clinical care. We're in university, province Swedish, whatever it may be. And there are a few independents around, I think. But even if you're an independent doctor, you're working in a system of some sort. And so, you have to be really clear about where you're really making your intervention. If you're making an intervention that's going to require a whole system change, you may have a much longer horizon to get it in place, but you have to also have a different strategy. than something that can be done more, I'll say, without having to change the system. And I think that's a huge difference between the two. And a lot of people think, well, I just go to one clinic and I can get it started there. But if they're part of the Wenatchee Valley Clinic, they may be able to try it out, but they may not be able to adopt it even themselves, even if they like it. So you have to think about it strategically too.
Allison, final thoughts.
I'll just close with highlighting a comment that Bob made, which is that thinking about who your audience is and really doing the formative work that needs to be done to listen to what their needs are and what solutions that they want, I think is really important.
Matthew.
I'd just close with just thinking about the needs of the end users as just the most important thing, not coming up with a solution for a problem that doesn't really exist or is not as important as many other problems that are stacked up. So I'd think about that. But really interested to see who applies and what kind of innovations and ideas we may get to work with.
Fantastic. Thank you all for being here. Please join me in thanking our panelists with a round of applause. Now, a couple of dates. Applications are open today for our Fall Trails competition. They close on October 1st. And then the final pitch competition to crown the winner will be held in Arlington, Virginia on November 14th with the Reducing Physician Burnout Symposium hosted by World Congress. So this is a very exciting opportunity to be able to pitch your solution in front of the World Congress audience. So please, again, look at our website, join the competition if you have a solution that you think can address this problem. And thank you again for being here. All right.